Get going here. Okay, great. So we're recording right now, and good evening, everybody. Thanks for joining. I was explaining to Tom that we have kind of a mixed group of folks here this evening, and it'll be great to kind of just meet people who kind of are just interested in the topic and want to know a little bit more. This is what I do occasionally. I wish I could do these actually more frequently and more consistently, is I have these little presentations that I call Impact Homelessness. And the goal of those is really to, for folks who don't know, like Tom and Carl, I am an independent COC and HMIS consultant. HMIS is the data tracking system that tracks homeless persons coming in for service. It's a federal initiative. And Paul and I became very close when Paul was working for a group he'll tell you about a little bit later, and then ended up going to work for HUD a little bit later, and he can tell you about that as well. So my living is really that I'm a COC and HMIS consultant, and the reason I started pulling some of these presentations together was because I realized that definitionally a lot of things get lost in our work. People get very confused about what they can and cannot do, what the eligibility rules are for services and whatnot. And then recently, after Paul left the administration, you know, when President Biden came in, Paul has started a coalition that he'll tell everyone about, but it's really around this idea of recovery housing. So, and Tom is also an expert, and he'll get to tell you about his background as well. I will say that my husband's on the call tonight, which is great, and he was the behavioral health housing specialist for Sonoma County for 15 years here in Sonoma County, and he's been out of that for about 6 years now, but he's got quite a bit of, you know, background and expertise in that. So what this kind of helps me by doing these presentations, because I figure out kind of more creative ways to design data collection systems that meet local kind of initiatives, not only the HUD initiatives, but I like the idea that people would be doing things on a local level so that they could maybe have a little bit more true impact and changes in people's lives. And just so everyone, just a reminder, I am recording this, and I will send, I'm going to go ahead and send some studies out after we're done speaking here tonight. I have a big passion in the work of continuum of care to solve significant information gaps that I've seen, and I've seen that in just about every place that I've done consulting with across COC systems. So I like to identify problems and solve them. I don't like the term silo. I know that's used a lot, but I'm from Western Colorado, so just that idea makes me kind of itch and scratch a little bit. So I'm always trying to kind of blend those two things together. So I'm going to go ahead and let our presenters introduce themselves. So tonight we have Tom Wolf and we have Paul Webster. And so Tom, if you'd go ahead and start out and just let people know who you are and how I came in contact with you and kind of what your work is right now.
Okay, well, thank you. Good evening, everybody. Thank you all for being here. My name is Tom Wolf. I'm a recovery advocate and a consultant on the issues of homelessness, drug addiction, and drug policy. I have kind of an interesting background. So about 2015, I got addicted to oxycodone after surgery. That addiction grew over time to I was taking about 500 to 600 milligrams a day of oxycodone. That spiraled into heroin addiction and eventually spiraled into homelessness in 2018, where I lived on the streets of the Tenderloin in San Francisco for 6 months, struggling with the heroin and fentanyl addiction. I ended up getting clean by going to jail for a couple of months to get clean, and then I went to a 6-month inpatient rehab in San Francisco that was abstinence-based, and I've been in recovery ever since. I'm now an advocate for recovery to promote recovery. As you know, there's a huge drug crisis going on in San Francisco and in California in general. It's kind of a phenomenon, really, with the advent of illicit fentanyl, and it's affecting the homeless population adversely, and along with meth, et cetera. And so I just advocate for kind of sensible policies around this. We're kind of moving in all these different directions right now, and we're kind of leaving recovery in the dust, so to speak. Whereas I believe we need to be promoting that as a primary part of the continuum of care to help people recover from homelessness. So that's what I do in a nutshell. I'm really big on social media. I have a big Twitter account. I'm starting my own nonprofit. It's going to be called the Recovery Education Coalition, led by people in recovery, to promote some of this stuff. And I'm collaborating with other national organizations now as well. Thank you.
That's great, Tom. I'm really stoked about your new nonprofit. I want to hear more about it a little bit later. So thanks. So Mr. Webster, why don't you just inform everybody about what you do and how you and I met?
It's my pleasure. Thanks everybody for tuning in and being a part of this. I really do appreciate everybody engaging in this topic. I think it's a crucial topic right now, not just for people like Tom and folks who haven't experienced recovery, but for communities as well. I'm a legislative and policy guy. I worked in the House of Representatives for a number of years. I came back to my native San Diego in 2006 and worked for a state legislator in California in the Senate and the Assembly. Worked for the Chamber of Commerce as a policy guy, and then I found myself out of a job. And a friend of mine said, you know, there's a homelessness program in your neighborhood, and I think you would fit really well with them. I didn't know a thing about really homelessness or homelessness policy, but I found my way to this organization called Solutions for Change. It is a sobriety-based, high barrier program, and learned a lot about homelessness, learned a lot about human behavior, learned a lot about the policy and the federal programs with respect to homelessness assistance. Long story short, I got a call at the end of 2019 from the White House because there was some interest in the administration in what was happening in Los Angeles with their unsheltered homelessness crisis. And they asked if I would be a liaison between Los Angeles City, Los Angeles County, and the administration to see if there's ways that we could come together and exchange some resources and some assets and some grant money in order to address the issues going on in Los Angeles. That lasted for about 4 months, and then COVID hit, wiped everything pretty much off the table. And then I spent the rest of my time at HUD just really digging into the regulation and the NOFA and the policy. And Teddy and I had known one another for a couple of years at this point. And when I started really looking at the system performance measures, when I started really looking at the efficacy of the continuum of care, coordinated entry, HMIS, you know, that just opened up a whole box, more of questions than really answers. So after the administration ended, I really wanted to focus on those folks who are unhoused and untreated, not just folks who are unhoused, and those who are untreated, but both those who fit into that part of the Venn diagram that represent both. They're both unhoused and untreated, because in my analysis, those are the folks that are costing communities the most. Those are the folks who are having the greatest mortality and morbidity, and those are the folks that are really the most challenging to address. So we've been focused on some national initiatives to try to reform the policy and the programming of the homelessness assistance programs, and also to address things like treatment, both treatment for serious mental illness and treatment for addiction recovery. So that's probably more than I needed to say, but that's a little bit about me.
Okay. Well, thanks to both of you. I'm going to go to the next slide. And let's see, I wanted to just talk about a little bit what we're going to talk about and how the evening would go this evening. I would like, this is a small group on the call, which is wonderful as far as I see. And I'd like to just say that I have prepared some slides. However, they're more just to set some framing. But Tom and Paul are going to actually weigh in on each of these slides as we go along. And I thought tonight we could talk about just what is the definition of recovery versus housing first models, and where are some commonalities and where might they differ. What's our current state of affairs? I did some research on this starting about a week ago. I wasn't, how do I say this? I was depressed at the information that I saw. And especially, you know, there's been a lot of media coverage and studies coming out of San Francisco that Tom can talk about. But I think that as shocked as I was about the increase in substance use in folks living outside, I was very, very kind of upset by that, and I think it would be good to kind of level set for everybody what's going on, but in a regional level more so. And then I thought we could talk about what are those commonalities between recovery models and housing first, because to be honest with you, the research I did, I'm seeing a lot of overlap, and I have a hard time understanding where the debate's coming in. And then Tom and Paul can talk about their advocacy work and where they see the needle maybe starting to move around this and what the policy trends might be. So Tom and Paul, I wondered if it's possible, if you think that it would be comfortable for you to kind of answer questions, kind of stop on each kind of major segment and then answer questions that might come up rather than waiting until the very end.
Absolutely. I think that would be best.
Okay, sounds good. All right, so everybody just feel free to dive in, and I've got two computers going, so I'm going to try to see when your hands get raised or there's a chat, so we'll start there. So again, Tom and Paul, I need you to weigh in. These are the printed definitions I was able to come up with in the past week. And I'm happy to send out these information sources to people when we get finished. I'll send these out tomorrow. But there is a group out of Nashville, Tennessee called Pathway to Recovery. And a very recent publication came from March 2018, where one of the researchers said that recovery housing is a valued part of the continuum of care for people struggling. It includes a full range of treatment and support, recognizing addiction as a longer-term management of a chronic illness or a chronic disease. And then strangely, because I've been seeing kind of like some stuff coming up on Twitter, especially Tom with you and Paul, some kind of counterpoint posts with the National Alliance about housing first versus recovery, but I did actually locate a HUD recovery housing policy brief. It goes back to December 2015. The only thing that I can find that is more current is a new program pilot called the Recovery Housing Program that Paul will speak about. But generally, you can see the two definitions kind of align. And so the second definition is abstinence-focused residential housing program where people can live and be supported by a community of peers, ensuring housing options available for people at all stages of recovery. The only difference is that through that housing first overlay, this is clients being offered a choice and having their own decision to make about going into recovery housing. So we can talk about that a little bit more, but I just want to set a little bit the current state from my perspective after doing this research for about 2 weeks now. There's not a lot of information out there. And I would like Paul to talk about that. I know for sure that, I wrote to one of my old managers at Alameda who's moved to Santa Cruz in the past year. He's probably one of the best behavioral health housing experts I've ever had the pleasure to meet. I asked him what the current data was, and he said really not much more than the point in time count. So Paul, I would love for you to talk about that in just a second. So I'm a little frustrated that our government is not being able to have timely data to identify how the current scope is changing, and I have a couple graphs to show as we kind of go through that. And generally what Dr. Ratner told me on an email today was studies find that between 25 to 33% of people experiencing homelessness at any one point in time have a serious mental illness. So that's a definitional issue, and I think where we get really hung up in our work is we don't know what all the definitions are. There's like, self-declared substance abuse or mental illness, there's like diagnosable, there's all these different levels that hopefully Tom and Paul can speak to. And then he pointed out that the general population, oops, sorry. That's okay. In the general population, the rate of serious mental illness so it's 6x higher for prevalence among people experiencing homelessness. For general behavioral health issues, not necessarily defined as serious mental health in the world, rates are significantly higher, 40 to 60%. And I did get one more statistic from our local gospel mission executive director today that we'll talk about. And then Robert sent me a study, just out from San Diego, found that 15% of people served in a public mental health system experienced homelessness in a single year. So Paul and Tom, can you weigh in on kind of like what you think the current state might be more so looking like, at least for California or the Bay Area?
Who wants to go first? Paul, you want to go first?
Sure. Thank you, Tom.
Yep.
So I think there's two significant questions that communities are struggling with right now. The first question is, where can people go? And the second question is, what happens to them once they get there? And so what's really happening now is that as communities see what's happened over time with the creation and provision of permanent supportive housing and rapid rehousing as part of the Housing First prioritization in the HUD's Homelessness Assistance Program, and here in California, with respect to the state's impact with Project Room Key, Project Home Key, what we're really seeing in terms of policy and policy implementation is a priority to house people. According to HUD, that providers of homelessness assistance programs are required to offer services. There's a variety, of what those services could mean, but the challenge is for folks who have significant needs, whether they're addiction, whether they're mental illness, oftentimes those services don't lend a sense of stability or a sense of improvement for that person. It may get them off the street, it may get them into a place, which is great, but it does little in terms of impacting people's improvement, sobriety, stability, mental health improvement, things like that. So what's happening with the current state is we're seeing a lot of recidivism back to homelessness, because we're able to offer people units, but we're not able to necessarily keep them, particularly in a place like California that, for lack of a better word, really supports and enables people to be on the streets and be addicted and be untreated. So what we're really seeing is, and it's fascinating. There was a focus group study in Los Angeles that just came out a couple weeks ago, and the public really sees the connection between untreated addiction and untreated mental illness as significant drivers of unsheltered homelessness, and I think that's what's happening.
Okay. Tom, do you have any comment about, I think maybe if I go to this next slide, Paul sent me this slide today, which came from California Policy Lab blog, October of 2019. Now, 2019, a lot's changed according to what I'm seeing in the figures, which again, were hard to find. But that unsheltered, let me go back just a second. Unsheltered people were more than 4 times as likely to report conditions that had contributed to the loss of housing, nearly 3 times as likely to report mental health conditions that contributed to a loss of housing, and more than 8 times as likely to report that use of drugs or alcohol had contributed to loss of housing. So can you speak to kind of, and I'll go to this slide too, Tom, that I found in a Chronicle article that Kevin Fagan did. They just updated it a couple of weeks ago. But can you speak to what this trend is showing right here? Deaths from drug overdoses in San Francisco?
Yeah, and there's a few things. And let me just back up just for a quick second to talk about the permanent supportive housing that Paul was alluding to. So look, in San Francisco regionally, we have 11,500 units of permanent supportive housing in San Francisco, and we're about to add 3,000 more. It's the most permanent supportive housing per capita of any city in California. Okay, so we actually do more, believe it or not, in San Francisco to house the homeless. Now, we can talk about, the recovery-oriented housing within that permanent supportive housing, people living in dilapidated hotels, and as an example, in 80-square-foot rooms without a private bathroom, without a kitchen. That's not very recovery-oriented, and that does not lend to the long-term success of that individual that has been placed in that permanent supportive housing and has been checked off by Housing First as being housed. Okay, now fast forward to the drug issue. This slide you're looking at here with the drug overdoses, you see how it started to increase in 2019, 2020, and 2021, and that was because of the advent of illicit fentanyl that hit the streets in large quantity in California, specifically in San Francisco. That has what has driven the overdose rate. 74% of the overdose deaths in San Francisco last year were from fentanyl, period, were from illicit fentanyl. Now, the weird thing, or the interesting statistic that's deeper than that, is that only 40% of those deaths were unsheltered people, were homeless. So 60% of those people were living inside. And the majority of those people that were inside that died of drug overdose were in the Tenderloin neighborhood, which is predominantly permanent supportive housing.
Wow.
So that statistic right there is very, very telling, in that it's not necessarily the housing, it's the services that we're offering. And if I could just expound a little bit more on that, a lot of people point, and this is where the conflicts come on Twitter that we talk about, Teddy. People always point to Finland, saying housing first works. Look at Finland, look what they've done in Europe, right? Which is like comparing apples to Legos. When you think about the issues that we have here in the Bay Area and in California and the United States, they had 4,400 homeless people in the whole country of Finland. We have 500,000 in the United States and at least 161,000 in California, right? And those permanent supportive housing units are run by the Salvation Army mostly, which is kind of ironic also. And so, you have to look at those things. So they have recovery-oriented housing as the housing first model in Finland, and it works there. Here, we allow, we have permanent supportive housing in the same neighborhood that we have prolific open-air drug dealing and the proliferation of illicit fentanyl. And now you're seeing the direct results of that inside permanent supportive housing. And that should be really ringing the alarm bells for everybody that's involved in the issue of homelessness and housing, as to what do we do about that? Because the very vulnerable population that we are trying to help the most are the ones that are dying at the highest rates because of the drugs that are out there on the street. And what are we going to do about that?
Tom, since you have kind of direct experience with this, what has caused this blow up? I mean, obviously people know that, it's probably not great to become involved with methamphetamine or fentanyl. What in the heck has blown this up? I'm just curious.
Well, what's blown it up is that in 2017, if you look at that slide, in 2018, when I was out there, everybody was using heroin as their opiate or opioid of choice, right? Then illicit fentanyl hit the street, and fentanyl became an opioid replacement or opiate replacement. It replaced heroin. It's not like the East Coast where it's being mixed into the heroin. In San Francisco, it has replaced heroin completely on the street as the drug of choice for people that are struggling with opioid use disorder. Okay, so as a result of that, and because fentanyl is 10 to 100 times stronger than heroin, you're seeing the overdose deaths rise in conjunction with that.
I just want to respond. One of the books that has really profoundly impacted me this last year has been a book written by Sam Quinones called The Least of Us. And that book, Sam originally wrote a book called Dreamland that you may be familiar with, that chronicled, the rise and the causation of the opioid crisis, from drugs like OxyContin being overprescribed, and then what he does in The Least of Us is he really documents the market impacts of synthetic methamphetamine and illicit fentanyl as not only being significantly different with respect to the neurotransmission and how people's brains respond to that, but also in terms of the market economy. So like Tom said, if I'm an addict and I can get a better high from something that's less expensive and easier to get, why wouldn't I do that? And so that's what we're seeing a lot, particularly among the folks who are unsheltered and homeless, and the relationship with just the market impacts of being flooded with P2P methamphetamine and illicit fentanyl.
Tom, can I get you to just restate something that I found very compelling, which is of this chart of these deaths from drug overdoses in San Francisco, how many did you say, 60% or 40% were in permanent supportive housing? So a smaller number than the total drug overdose chart that we're seeing here.
Right. Well, this is the big misnomer in San Francisco, is people see these deaths and then they see images of homeless people and they just assume that all of these people that have died were unsheltered folks. and that's not the case. In fact, the majority of the people that died of drug overdose in San Francisco were in fact housed in permanent supportive housing. And that's something that you can break down, and I've broken it down. It took me a while, but in 2021, 2020 stats, I broke them down last year using the county medical examiner as to the address. And so did the Chronicle. They also broke it down, the San Francisco Chronicle, as to the location of each one of those deaths. And the majority of them were clustered in the Tenderloin, which is the 80%, 70% of the housing in the Tenderloin is permanent supportive housing, which tells you that those drugs are being taken indoors and being used indoors, and unfortunately people are dying because of the said drugs. And that's something that we're not talking about enough, and this should be talked about more when we talk about services that are being provided to people inside permanent supportive housing, to give them options so they don't get to that last option of using a deadly lethal dose of fentanyl and overdosing and dying.
So I'm really glad that you kind of highlighted that and you were able to talk about that again, because none of us in the work, and I'm sure you're the same way, none of us want to stereotype what's going on for people that have fallen on hard times, difficult circumstances. And so that was an interesting statistic that you just afforded us now. So we can't go strictly from, everyone lives outside, therefore, it's not a one-to-one relationship or correlation, I guess.
Right, and that's what the unfortunate thing is that it does get kind of all lumped together, and it's frustrating because you're basically have people on one side of this issue that are saying that drugs are only driving 26% of the people that are homeless or struggling with drug addiction, and everybody on this call knows that that is not true. It's just not true. And so that's what kind of drives it, is that there are being half-truths told along the way to justify certain data, pieces of data that are then being utilized directly towards funding. And that's something that needs to be looked at a little closer. And forgive me if I'm being too honest. I'm just telling you the way that I've experienced it. I worked as a case manager in permanent supportive housing too, early in my recovery in San Francisco, in the Tenderloin, 2 blocks from where I was homeless, and drug use was a huge issue. Huge issue.
And I think
I'm
also,
read...
to your point, Teddy, is there are these kind of societal trends that we're having to deal with, influx of drugs, challenges with economic issues, housing shortage, housing availability, et cetera, et cetera. But I think one of the things that I've focused a lot on is just the policy. And the policy coming down from the federal government that was affirmed by the state of California and affirmed by cities like San Francisco, Los Angeles, Sacramento, is you can't have flexibility and diversity of approaches when it comes to issues like tying housing to treatment, tying housing to things like sobriety. And I think that's a big challenge. I'm not here to say we got to wipe out all this permanent supportive housing, because it doesn't insist on certain treatments or certain things like that. But we need to allow people and communities the flexibility to choose the approaches and to choose the kind of housing, whether it's recovery housing, whether it's transitional housing, whether it's permanent supportive housing. We need to be unshackled from the policy constraints so that we can address the issues as they're rising in our communities.
So I'm going to read everybody an email I got from Jeff Gilman this afternoon, and then I want to open it up for questions for just a little bit. For folks who don't know, who are out of the area, Jeff Gilman is just a wonderful executive director here in Santa Rosa, California, of the Gospel Mission. And so if we want to talk about population terms, Jeff's programs take on, as I'm sure your contacts do in LA, Paul, Jeff's programs take on what we call the more chronically homeless group of people. And I wrote to him today, and Adrian, who's on our call before she leaves, may want to weigh in on this. But I asked both Jeff and Adrian that based on your current experience, how have you seen your clients increase in substance abuse over the past 3 years? And this was Jeff's response, and I don't know, Jeff is not really an active member of the continuum of care here locally, but I think he's a wonderful provider. And he said, based on our experience, that number is north of 70%, maybe even as much as 80% for those living on the streets. I believe that percentage has increased somewhat in the past few years, and you won't be surprised that I think public policy has been a contributor, if not a driver of that increase. So there you go, Paul and Tom. You might want to use this in your advocacy work. One would have to have a blind spot not to see that the disaster has been our current public policy. It is a confluence of Goodhart's Law and the COBRA principle, both of which I had to look up today. But, you know, Adrian, I don't know, you've mentioned on some of the homeless action meetings that you have noted more substance use in the folks that you're serving, and I didn't know if you wanted to speak up at this point.
Well, I will certainly say that what they're saying about fentanyl and the way fentanyl has increased deaths and addictions, I would say also because of how easy it is to get and how much it's laced into every other thing, even aspirin sometimes, you know, that it's just, it's a huge problem. What I don't see is, I'm not someone, I can't tell you. I feel like I'm not expert enough to give you the kind of numbers that Jeff is doing or to validate his numbers. But I do think that no one that I know knows how to deal with it. Like if we had the money, and I'm seeing in the chat, Tom saying treatment on demand, but what kind of treatment? I mean, are we talking about residential treatment? What actually helps?
I think it goes back to these two questions that communities are struggling with. Where can people go? And what I mean by that is where can an addict who's seeking recovery go? You know, Tom has a great statistic about San Francisco, and that in a city of 25,000 confirmed addicts, what do you have, 35 detox beds? Is that kind of around the
55 detox beds and 500 treatment beds that are sanctioned by the Department of Public Health for a population of 800,000 with at least 25,000 drug users. Yes, that's correct.
And then you know, I just ended a contract with the city of Chico. The entire Butte County has 0 detox beds in all of Butte County. So, you know, you have to think about in terms of what's the appropriate place for people to go. Where do people go after their 72-hour hold of being in a 5150? I mean, you're right. Is it acute care? Is it subacute care? Is it step down? Is it board and care? Is it adult residential facility? Is it recovery housing? We don't have enough places for people to go. And combined with that, when you start looking at the behavioral health dollars, the MHSA dollars, you know, what kind of quality and long-term treatment is available so that people will get what they need and recover and stay there and not recidivate back, not relapse, not have a psychotic break where they stop taking their meds and they're driven back onto the streets. So to me, the real issue is where can people go and what happens when they get there? Why are we satisfied with this kind of panacea approach that permanent supportive housing is going to be all things to all people when we can see with our eyes that that's not the case? And how do we then go about and try to change the system so that communities have greater flexibility, so that we're incentivizing a greater diversity of places for people to go that address their specific needs, and that we're supporting that treatment with appropriating and allocating the right resources so that we have the kind of treatment, we have the kind of resources, and we have the kind of housing that is actually going to result in positive outcomes.
So I would have to say in Sonoma County, it's similar. You can get a 3-day crisis treatment and then there's nowhere for you to go, 99%. And where you do go, the thing I wanted to drill down is, suppose that we found funding for a whole bunch more of this stuff, which I would certainly think is great. What kind of programs actually help people get off of this very, very intense addiction? I don't think it's even the same as heroin. It's really hard. So that's one thing. And yeah, and I guess the other question is like, okay, so if we have a limited pot of money, if the money is like, well, this is what the feds have given us this year, are we really going to take people, put them back out on the street so other people can have treatment?
Well,
I don't want to make that bargain.
yeah, and to your point, I mean, look at it from the other way. If I see a high cost individual, am I and my performance measures are driven by housing stability? You know, do I want to go with someone who has a lower acuity? It's kind of like there's an oversupply, or there's too much demand, so that providers can kind of game it a little bit and kind of look for the folks that, I mean, and this is the same criticism that's given to high barrier shelters. Well, you guys are cherry picking, and that's why you're getting good outcomes. Well, you know, the same can be said for permanent supportive housing, because you still have this challenge of the demand is greater than the supply. So how do you regulate that? And that's a challenge. And particularly when you don't have enough options. I mean, Andrea, I think this is exactly your point. When you don't have enough options because of whatever, whether it's, you know, lack of funding, whether it's, you know, MHSA dollars not going, you know, to the creation of housing or facilities, whatever that is, it creates so much constraints in the marketplace that you get the kind of results that we're getting.
I wonder if, you know, one of the things we talk about a lot is let's do a quarter-cent sales tax for homelessness, or an 8-cent or whatever. And I wonder if this motto that you have, treatment on demand, if that's something the voters might really support.
Well, the irony is that in 2008, San Francisco did support it. They passed a measure in San Francisco, a Proposition T, to order treatment on demand become available. And the Department of Public Health every year since then insists that they have treatment on demand. They go in front of the Board of Supervisors every year, and they give them like an 8-page PowerPoint saying, we have treatment on demand. And their definition of treatment on demand is anywhere from 1 day to 8 days of treatment. But every year, there's all this evidence that shows them that it takes up to 50 days to access a treatment bed because of lack of access, lack of options, lack of medically assisted treatment options. And then they won't, the Department of Public Health won't include any abstinence-based treatment programs in their continuum of care, because they've written into their RFQs that any treatment program that's inpatient must be a harm reduction program and can't be abstinence-based care or program. So it's really complicated, and there's a lack of funding behind it, which is true, but there's also a lack of will to kind of make certain trade-offs that need to be made. Like for the folks that are like all abstinence only treatment, and that's where I came through that pipeline. You know, it's with fentanyl, you're right, Sharon, it's a drug that you can't kick cold turkey. Some people were able to kick heroin cold turkey. You can't kick fentanyl cold turkey. It's too strong. You need Suboxone, you need buprenorphine to kick it. So we need to look at ways to you know, and they're doing some things at the federal level with the X waiver and things like that to make MAT more mainstream in this country. And that's something that's going to have to progress over time to become more widely available for people, because that's going to be one key to helping people. And then creating various types of treatments going to have to be another key. Increasing the detox beds is going to have to be another key. Step down housing is going to be another key. And you know, when I say the Department of Public Health offers 500 beds, that's not just inpatient drug treatment. That includes their step down and long-term residential programs too. So it's really far less than that, the amount of actual treatment beds that they have to offer people struggling with addiction. So one of the ideas that I thought that I've seen put into action here, believe it or not, in San Francisco, is the idea of incentivized treatment, which the reentry division of adult probation is doing a couple of programs with a very high success rate of right now, where they're basically telling people exiting the criminal justice system that, hey, if you're struggling with drug addiction, if you complete a 6-month inpatient program that will help you get into, we will guarantee 2 years of transitional housing upon exit. And that's having an incredible success rate in helping people stay clean and sober, and even for people that are on MAT to eventually transition off of that MAT if they want, but they don't have to. And I think that that's where the harm reduction and abstinence and treatment can all work together to create a situation where we're not just getting someone off the street, but we're changing their quality of life. Yes.
Excuse me, could you explain MAT again?
Yeah, medically assisted treatment. It's the use of Suboxone or buprenorphine or methadone. Those are the two primary ones. There's another drug too called Vivitrol, which people can take, and it's those are opioid inhibitors. So when you're in withdrawal, acute withdrawal from opioids or opium or opiates, these are inhibitors. They wrap themselves around your pain receptors in your brain and allow your pain receptors to become immune from the withdrawal or the craving of the actual opiate itself. So it's a really great drug. I took it when I went to jail. They gave it to me for 5 days on a taper. I was in full heroin withdrawal, the sweats, curled up in a ball, the whole bit in county jail. They popped 2 pills under my tongue, and in 5 minutes I was sitting up and I felt normal. It was amazing. It actually really works. And that's going to be the key for people that are struggling with fentanyl addiction, because Sharon was saying it's a different kind of drug. I agree. You can't kick it cold turkey. There are very few people, if any, that have kicked it cold turkey. They end up going back and relapsing and possibly overdosing. But this drug really stabilizes that individual and gives you an opportunity to sit down and introduce that individual to recovery.
And I think on the policy side, to kind of tag on what Tom is saying, you know, let's think of this both in terms of housing for the homeless and also in terms of recovery. There are some, but there are fewer and fewer people who are just dead set on this notion that no, we've got to get people ready for housing before we house them. That's kind of an argument of the past. At the same time, because of these trends in these new illicit drugs that are on the street, very few people are saying, you know, abstinence is the only way. You must be completely, you know, the only way to kick these things is abstinence. And so, but the challenge is, is that what is the policy incentivizing? With respect to recovery, the policy is incentivizing medically assisted treatment only. It's not providing flexibility for people to get stable on medically assisted treatment and then get the same support in an abstinence program. And the same thing on the housing side. There are great programs that do transitional housing, that have sobriety-based housing for a population, but the policy says no, you must be committed to low barrier permanent supportive housing. And I'm not suggesting that low barrier permanent supportive housing doesn't have a place. What I'm suggesting is, for places like the Salvation Army, for places like the rescue missions, these guys have been in business for hundreds of years. And we're just simply saying, because of ideology or whatever, we're saying, nope, we're no longer interested in that model anymore when they're helping millions of people. And I just think that that's a short-sighted, ideologically driven approach to the policy.
We are going to talk about some of the comparisons to Housing First with the recovery model, and especially where the busting is, because I know Tom, you have an interest in that, and I do too. But I wanted to also find out from Oliver or Denise or Carl, Althea, anybody else, Sharon, do y'all have any different questions, Frank? I know Frank's done quite a bit of reading on Schellenberger and Quinones. So any other questions at this point?
Hey, Teddy.
Hey.
Hey, it's Frank. Hey, I just wanted to just make a comment. I've been putting some stuff into the chat, but I can tell you that one of the difficulties at a local level, especially for interested parties, interested local, not necessarily politicians, but just people like me who have an intense interest in seeing things improve, and notice that it's extremely difficult to punch through the high housing cost narrative. Where I'm living in Deschutes County now, as some of you probably know, that the narrative is that, well, high housing costs are the reason why people are sleeping in tents on city streets. And it's very difficult to punch through that narrative, even when you give them plenty of information to the contrary. Their confirmation bias is so strong that they just simply won't even entertain any other information. So I'd be curious to see if anyone else in their area has had any success in getting local politicians and service providers to at least listen.
Well, you know, so in San Francisco, that's probably the greatest challenge of all. And I read your chat and I'm sitting here nodding, going, yep, that's the same thing that we hear here too. And look, there's some truth in that. That's the thing, is that all of this stuff is, there are truths. In all of this stuff, there's truths in that poverty is a driver of homelessness. There's truth in saying that systemic racism is a driver of homelessness. There's truth in saying that the high cost of housing is the driver of homelessness. Those are all truths, but they're not the whole truth. And I think that's what's frustrating, is that there's a group of us now that are coming from the side saying, okay, all those things are true, but what about the 200,000 people that are homeless in California right now, already unsheltered? What are we going to do about them? And then we say, build more housing. And then today, the controller in Los Angeles releases a report saying that the average cost of one unit over there ranges between 500 and 800,000 to build. And all of a sudden, politicians are like, well, you know, they don't want to talk about it anymore. So they say, well, Project Roomkey. Well, Project Roomkey takes 2 years to flip a hotel into permanent supportive housing. What happens to those people on the street for those 2 years while they wait for that housing to come online? Those are the kinds of questions, and that's where the conversation gets murky, because we want to talk about root causes, but we also have this crisis that's staring us in the face right now of all these unhoused people on the street. What are we going to do with them right now? And the two can't seem to make the connection together, that it has to be a combination of, you know, increasing the shelter system, increasing drug treatment, while you build out housing at the same time. It's okay to do both. Both of them are the right thing to do, but we can't seem to get past that it's only a housing issue, so we only must build housing and defund everything else along the way. And that is what has happened over the last 7 years. And I think, Paul, you can corroborate that too. And that's created this, you know, it's helped contribute to the situation. So Teddy, when you were talking about policy earlier driving this crisis, that's part of the issue as well.
You know, I have to totally agree. That's the frustration for us as residents here in Sonoma County, is what we hear over and over. And I think it just did it to itself, because the framing of calling it a homeless issue as opposed to calling it a homeless and addiction and mental health issue gets people a very narrow view of what's needed. And in their mind, it's just like, all we need is housing. And we're sitting here with a county that spent $92 million in the last year on homeless programs. And I'm going to guess that our point in time count on Friday isn't going to change much, because it's just throwing money at anything that is a funded program by the state or the feds. And very few of those programs have an element that is calling out, you need to provide so much mental health support, long-term, you know, care for, you know, to get addicts off the street and treated. It's like everybody is focused on housing, and it's such a narrow vision that we have a service provider in our neighborhood who's been here for 20 years and tells us in meetings, we're only going to look at housing first. And so what you see is these people that are extremely mentally ill and possibly addicted to both, just wandering our neighborhood all the time. And it's just, I can't even believe that a service provider would fund themselves, you know, would focus just on housing first when they see what's going on around them on a daily basis. But that's what they do, because that's where the money comes from. So I'm curious if there's any way that we're seeing some kind of break in this philosophy that it's only a housing issue coming from HUD, coming from the state. Is there anybody who has a more encompassing view of where to send the dollars so they have a, you know, a true impact on how many people are living on the street?
Yeah. The news from HUD and the United States Interagency Council on Homelessness is that homelessness is caused because of racial inequality. So I'm being truthful, but I'm kind of being sarcastic at the same time. So the point is that here's what's happening is we have these two narratives that dominate our conversations with respect to homelessness. The first narrative is that homelessness is caused because people can't afford the rent. And the second narrative is that housing solves homelessness. And so what happens is when you repeat those narratives over and over and over, people believe that homelessness is strictly an economic issue. I had a conversation with a guy in Austin, Texas, who was part of the State Department of Transportation. He told me that 85% of the traffic and pedestrian accidents involve the homeless. And because I'm a sarcastic guy, I said, why is it that people who can't afford the rent keep finding themselves in the path of cars? It doesn't make sense. There's something else going on. But that's the challenge is when you frame the issue as economic and a lack of housing, and then you ask people about homelessness, they say, well, if they're homeless, give them a house. But what's happening in San Francisco and what's happening in Los Angeles is the public is seeing the failure of this housing only approach, and they're seeing what's going on in their communities. And they just like you said, there's so many people that are visibly in psychotic states and they're untreated either for addiction or mental illness or both. They don't believe what's coming out of the mouths of the politicians. In the focus group that I mentioned in Los Angeles, the number one highest resonating message was a complete lack of faith in the elected officials to address homelessness. And that's what's happening. It's this complete cognitive dissonance because they've been told one thing and they see another thing and they're trying to make sense of it.
Is that what Karen's running on? Just curious. Karen Bass. Karen, what's her name?
Karen Bass, mayor of Los Angeles. She, you know, this is really fascinating. So in Los Angeles, the number one polled issue, and I'm sure it's true everywhere else, is homelessness and crime. And so every candidate, I mean, Los Angeles is in a really amazing, you've got the mayor, you've got the city attorney, you've got the city controller, and you've got, I think, 8 out of 15 city council members who are up for re-election or election, open seats, whatever. And everybody is talking about homelessness. So Joe Busciano just introduced a ballot measure that really focuses on street enforcement. He's running for mayor. Then you've got folks like Karen Bass, who really aren't saying much, but they're not making the pragmatic connection, the policy connection between mental illness and addiction treatment, which is the purview of the county in California, and the provision of shelter, which is mostly the purview of the city. And so they're saying the right words, but they're not making the connections so that it really actually turns into some pragmatic policy improvements.
You know,
Can I chime in with a question?
I'd like to chime in with a comment.
me too, Adrian.
Okay, I'm sorry, did you, because Oliver hasn't spoken, did
Yeah,
you?
yeah. I've just some ancient history, really. I did a lot of reading about steps last year, you know, which is which is kind of what was fashionable before Housing First. And, you know, the whole steps program basically had incentivized treatment, you know, speaking to what Tom was saying earlier. You know, if you come out of prison and you're addicted, and you're incented to actually go into treatment for 6 months and you get 2 years of housing. That sounds an awful lot like the old steps model, which predates anything to do with Housing First, which is clearly in California a complete chimera because there's no way that's viable financially. Jerry just put in the written comments here that I'm just scrolling, but Sonoma County unit is $690,000 to to house one person or to create one housing unit. So this is a complete non-starter, and obviously the political situation is an absolute train wreck at the moment, with a lack of clarity about anything really other than throwing money at the wall and giving huge amounts of money to non-profits and hoping they do the right thing. So I'm just interested, particularly Paul, you know, if you've got any insights into, from a HUD perspective, on why STEPS was sort of sunsetted and housing first became popular.
Yeah.
Hold on.
Oh, I'm sorry.
Yeah, so I need to frame this a little bit in terms of the reality in Sonoma County and what we know in Sonoma County. So in 2016, there was a very good validated study of what the people in the county thought were the causes of homelessness and what were the causes of what the issues were. And it was very balanced and it was accurate. People understand the issues with substance use. People understand the issues with disability, those kind of things. So to frame it as an either or is not accurate for Sonoma County based on that 2016 study. In terms of the housing and the, you know, if you ask why housing has gone from 390,000 to 450,000 to 550,000 to 620,000 per unit, in San Francisco, it's about 750,000 per unit. That's a conversation that we're simply not having. And that's a conversation about the affordable housing industrial complex. That if you look at the executive salaries of the major housing organizations that we all could cite, Burbank, Mid-Penn, EAH, those kinds of things, Burbank is actually there, and you can see this by looking at their 990s, because in their 990s, they report their executive director's salary and they report their sort of stepwise salary underneath that. So in Burbank, is the lowest paid high executive, and he's getting 200,000. The highest one that I saw is the guy who runs Mid-Penn, and he gets $500,000 a year in salary. So and if you look at Housing California and the organizations and the banks and the accountants and the consultants, the affordable housing industry is just that. It's a developer industry that serves the developers. It may in fact create housing that's usable, but nobody questions the expenses that are associated with it, or the way that the tax code has incentivized expanding the cost of affordable housing so that 30% of the cost of building is the tax credits. So just sort of bring that around to everybody to think about that. And I have lots of thoughts specific to Sonoma County, but baseline, we have to have a distinction between how we talk about what the people believe about the problem and how confusing and disingenuous or even compassionate and incorrect politicians might be.
Yeah, Jerry, I love what you said, and if you want to trace that back to a policy change, look at the prioritization of permanent supportive housing and the decline of transitional housing. One of the things that HUD wanted to do, and just as kind of a follow-on to the affordable housing developers, they wanted to reduce the number of people that were in programmatic contractual housing, like the Salvation Army. We'll provide you housing, we'll provide you meals, and you will live under a programmatic contract because you're required to do this, do that, and the other thing. They wanted to get away from that, and they wanted to incentivize people getting housing through leases. So when you're in a lease, you're now protected under the Fair Housing Act. So part of the push was to say, we want to do away with contractual programmatic arrangements for people with respect to housing and treatment and services. And we want to incentivize the coverage under the Fair Housing Act, which can only be done through a lease. And so, to your point, we've incentivized these developers instead of understanding what is the most efficient, economic, and effective means of housing people and producing results. And that's how Teddy and I really started, talking about performance measures, talking about what metrics need to be collected, talking about iterative processes by which communities can then make decisions, year after year to say, let's really chase after some of these metrics and these performance measures. But those kinds of efforts and that kind of thinking is really discouraged because it's just not happening in so many of these communities.
You guys, Althea has a burning question, but what I'd like to do is just, Althea, if you don't mind, I'm going to forward through my comparative slides for Housing First. And then Tom, if you could spend dedicated time answering Althea's questions after we kind of go through the commonalities. And these are the ones I have found, so I need you guys to tell me where I'm off track on this. This is something that Brian and I have been talking about in Lake County because they have very new Housing First State Welfare Code contracts up there, and Housing First is a new concept for them and kind of a surprising one. So here's in my research what I found, but I'm going to stop after I get done on this slide and just show and just ask you, Tom and Paul, to weigh in on where I'm misunderstanding the debate here. So in looking at the few policies that I could find that talk about recovery housing and Housing First, and by the way, Althea, I will just let you know, and for everyone in Sonoma County, HUD did produce a policy called recovery housing. And it's a dated policy. It was done, published December of 2015, and Paul will have things to say about that. But I think that, saying that it's a little bit different to say housing is all we need versus housing is fundamental to recovery, right? Because Tom, would you agree getting someone out of the street scene into a safe environment is fundamental to recovery?
Absolutely. It's
whether
one of the
there's a lease or not.
It's absolutely one of the cornerstones of recovery. Agreed.
Okay. Let me go here. Would you agree, and this is what I'm finding in the research, there's an uneven classification of addiction as a disability across federal partners?
Of course.
SAMHSA defines differently. And Paul, could you weigh in on that? Because I asked you about that today.
Yeah,
about the misalignment of the federal partners.
Yeah, so here's the real challenge is what HUD has done is they are relying on SSDI and SSI qualifications in order to pencil out permanent supportive housing. And so there's a real push for qualifying people. In fact, SAMHSA has a program called SOAR, whose purpose is to incentivize providers to get people qualified for SSI and SSDI. But I think the real problem is that you've got folks who are seriously mentally ill, you've got folks who are mentally ill, and you've got this whole spectrum of mental health disorders that are hard for homelessness assistance providers to really do much with. They know that there are people who they're not going to be able to serve because they're just simply too seriously ill for them to shelter, to have them live in like congregate housing, and sometimes even to keep them stable in permanent supportive housing. So I think there's there's a lot of truth in the impacts of this uneven classification. And it's not just the classification of addiction as a disability, but it's also the pay-fors. Where are people staying? What are the payment and reimbursement restrictions for the type of housing that they're in, for how long? It's just a real mess. And the result is it disincentivizes the provision of treatment both for the addicted and for the mentally ill.
So the next point would follow along with that, though, an inability to access certain income or benefits, depending on which federal program you are being served by. And I'm a real definition person, but I will tell you that the eligibility definitions across these programs just make my head spin. And so I'm hoping that the DEI work will kind of, unite some of the partners to make that a little bit more straightforward for people. The commonalities I found when people were writing about recovery versus housing first is that there's agreement that a service plan needs to be client choice driven and acknowledge expressed preferences. And Tom, I really want to ask you about that, because my next slide is going to be what's the beef, because I'm finding all these commonalities. When you're in recovery systems, are you forcing people into service? Is that what happens?
What do you mean forcing them into service?
Well, the way we've had it explained, because we've been working with HUD-TA up in Lake County, is that substance abuse treatment, mental health treatment can be afforded a client at their discretion. And so the only takeaway I had from that was, well, recovery must just force people to do all of these things as first steps.
So not necessarily. I mean, okay, so you're talking about like the difference between being forced into treatment, into a certain type of program, versus having your choice of program to go to. Is that what you're asking? Or
having a choice to go to program at all and being put straight into housing.
Okay, right. So, okay. So under the Housing First model, and because of decriminalization of certain crimes and changes to the law in the state of California since 2014 specifically, there's no longer any type of driving factor to use mandated treatment for the subset of people that are struggling with addiction, particularly those on the street, that would benefit from some type of intervention. Let's put it that way, okay? So that's a little more specific. There's a subset of people on the street that are struggling with drug addiction that require and would benefit from intervention. And those people are the people like I was, like me, that were committing crimes to support their addiction. Those people being forced or coerced or mandated into an inpatient drug treatment program would probably have some benefit to them and benefit to the community, because at least for that period of time, they're off the street, number one. And number two, that individual can then begin to address some of their other issues and hopefully find a pathway to recovery. The other one that you're talking about, the service plans need to be client choice driven and acknowledge express preferences. Look, patient-centered treatment is a wonderful idea. But the reality is, when it comes to drug treatment, there just aren't enough options out there to offer people patient-centered treatment most of the time. Okay, so it's like, this is why it can take someone up to 50 days to access a treatment bed in San Francisco. Because if that, I've had social workers that I've talked to, people that work for the Department of Public Health, deliberately not refer someone to one program because they're like, oh no, don't go to that program, it's too hard. Or don't go to that program because they make you go to church. Okay, these are social workers and case managers that are talking to someone struggling with addiction, that are literally hanging by a thread sitting in front of them, with their choices either being going to that program or going back out onto the street and using fentanyl. That's not right, and that must change. Okay, so that kind of stuff is what we need to address, along with expanding treatment and treatment options for patient-centered treatment.
And the last commonality that I was able to locate said that, both parties, or kind of both perspectives, agree that recovery models need to accommodate all recovery stages and include peer support. Those are effective measures. And that's in the HUD brief as well, Paul, the recovery housing brief.
I would say that we need to be good discerning consumers when it comes to kind of peer supports, because in the mental health side, they're basically substituting clinical interventions with kind of peer-driven support. And I'm not suggesting that that's I'm not trying to criticize peer supports, but I am saying that in a lot of circumstances, it's not effective with respect to clinical outcomes. But on the other hand, I think we need to do a lot more to create peer-oriented recovery communities. And I think this is one of the big challenges, particularly in addiction. We know that peer-supported recovery is an effective means of supporting people once they get sober. And I know too many addicts in recovery. I know too many people who are stabilized now, who are seriously mentally ill, who say things like, if I wasn't forced to get sober in prison or forced on meds because I was in a psychotic state, I don't know where I would be right now. So there's an element to compulsion, but after that, there is a huge importance of making sure that people's recovery or making sure that their stability is supported by other people who have been through it. And this is the challenge with low barrier permanent supportive housing. You have people who might have come out of drug rehab or come out of prison and experienced some time of sobriety, and they want to have that supported, but there's really no provision for that when it comes to where you're placed and the kind of housing that you're placed. And so what happens is you're not getting supported by folks who understand the struggle, and you're ripe for relapse. And I've seen that story happen so many times, it's heartbreaking.
Okay. So here's my big slide of the evening. So what's the problem? If we can agree on so many points, where is this problem coming in that we're going after each other on Twitter and having to use ideology when very rarely do communities, only the really well-heeled communities, rely deeply on data analysis or understanding this programmatic work? Where's the problem? Why can't we come together? Why can't the factions come together and agree that recovery is and then this is where we'll get into Alethea's question. I want to know on another slide, where are we moving the needle? Where are you two being able to move the needle to? But where do you think the problem is, Paul, about aligning some of the, I mean, this is just so obvious to me.
Well, I'll save that for later because I want to answer this question first before we answer, what my answer is. But I think the problem is that there are incentivized. There's an incentivized approach, and I've talked to people. I've talked to people in continuum of cares. I've talked to people of providers that are providers, and they don't want to buck the system because if they buck the system, they know that their funding is going to be threatened. And I know people whose funding have been cut off because they haven't, quote unquote, kind of towed the line, spouted the company message. And I also know people who have radically changed their program because they wanted to continue to be funded and continue to qualify for continuum of care grants. So there's a significant influence of kind of like, don't rock the boat, don't color outside the lines, because if you do, you'll be punished. And that's part of the problem.
Okay, so I'm going to jump here really quick and just say that part of the research that I did too is exactly what you're talking about, that the project type transitional housing has declined rapidly because HUD favored rapid rehousing as a solution going back to probably 2 or 3 years before the family options study. So along about 2013 was when we first started doing rapid rehousing in Sonoma County. But I had not linked until today. So Jessica, you can tell Colleen that I finally understand if you're still here. That Colleen was saying that, she was very upset about the loss and defunding of transitional housing, but I didn't realize that's where a lot of these treatment programs were happening, were in the TH projects. Just made that connection today. I was more on the eligibility side of it. HUD began defunding transitional housing, and where many of the recovery housing programs live through the COC collaborative application. And so for folks that haven't done COC competition, HUD started publishing years ago that your transitional housing projects were not going to score as high locally on the collaborative application. And so they started, when we do collaborative application scoring, we need to rank the projects. So transitional housing was moving down the list in favor of these rapid rehousing programs. And I will say that when I did rapid rehousing and did some costing on rapid rehousing when I was working in Sonoma County, our goal at that time was not to serve the most vulnerable people. It was to cream, as they call that term, to get people off the top and get them moved out of housing very, very quickly. So I think it's been a surprise for many providers that rapid rehousing, which started out being that quick way through to permanent housing, is now being looked at the most critically homeless folks. It's kind of a transition and a switch. And again, Sonoma County people, the HUD policy brief has stated that recovery housing should be part of a larger community approach grounded in choice for people experiencing homelessness and substance use. The current scoring criteria, however, does not support this approach. So unfortunately, and what I've noticed in my work in so many continuums of care, is that whether it's collaborative applicant COC funding specifically or not, that's what we calibrate to. The mindset calibrates to the collaborative application. When you look at it, even if you look at it a percentage of Sonoma County, that 92 million that Frank had done some research, we get 3.7 of continuum of care funding, but yet it drives the philosophy in our county. So I thought that that was very interesting. And then this is just a quick, I will send this out to folks, but for folks who are familiar with Joe Coletti, he's a doctorate working in Southern California with policy development. He's very outspoken at the state of California Cal ICH meetings. He's a real advocate for getting a PIT count done in every single county. And this is something that he'd done a couple of years ago, but just showing you the increase in shelter beds, the decrease in transitional housing beds, and then the PSH beds, and rapid rehousing more than doubled, which now we're seeing a cliff effect from that project type, right? So what I mean by that is that that project can go up to 24 months, just like permanent housing, but the pressure is to reduce the supports both financially and case management within a much shorter period of time, like 3 to 6 months. And we're now, in some people who've been transparent about the data, starting to see a lot of returns to homelessness from that project type. So, okay, advocacy. I'm going to let Alethea ask her question right now, Tom, because I think we've talked about advocacy, but she really had some great questions in the chat, and I think it rolls into this final slide.
Thank you. Thank you so much. My name's Alethea, and I work for the leader. Totally fine, because it's such a weird name. And we are a privately funded transitional housing program, relatively new and evolving. And really evolving based on what is working and what isn't working in our program and based on the needs of our community. And just a couple of weeks ago, actually, we created something called gap housing. This isn't part of my question, I'm aware, but this was to fill a specific need for folks who are going to be dipping into homelessness. They come out of a bed, like a CSU bed. They've got permanent housing lined up, but they've got a 6-week gap where they might fall into homelessness. We're accommodating that, or some immediate need before they're going on to that permanent housing. And so I think we're seeing some traction there. Simultaneously, we're getting ready to open our community center, which is for women and children in Sonoma County who are experiencing homelessness or are at risk of, and are really aiming to have recovery services at the center, and those are taking shape. And my real question is, we would really like to have recovery services aimed at our demographic of women under the umbrella of trauma-informed care as well, and with that peer-supported recovery help in the recovery of the center as well. And I was asking for your perspective, I guess more on a micro level than on a macro level more than a micro level, of where we should look for that model if that exists.
Well, okay, so that's pretty specific, and you're asking for a lot, and probably not able to pay very much, and all those things, right? So here's the thing, right? So one of the things that I learned and that I saw in my time as a case manager, and there's a pretty big recovery community in San Francisco. I know a lot of people in recovery in San Francisco that are in the business, okay, of recovery and helping people. So recovery coaches are a big thing up here in San Francisco, and people will do it for not very much money because they're in recovery themselves, and they're just trying to give back. And it's that whole each one teach one thing that many of us learned in like 12-step recovery as an example, right? Where you try to pass that word on of recovery to other people. And so having someone that has lived experience in the same room or same facility with a group of people that are going through it right now is literally, it's invaluable. The amount of support that that person can give, because not only is there the empathy, but they can share with them the best practices of how they got out of that cycle, right? That's one of the most effective ways that I've seen to help people that are struggling with homelessness, that are struggling with addiction, that are maybe early in recovery from one of those things, to give them the kind of support that they need. You can have clinical support too. I'm not saying that that's not extremely helpful, right? But having that lived experience factor, if you can find people that are in recovery, or maybe people that have experienced homelessness, that are willing to give back to their community. And that's one of the things in recovery, that's what we want to do. That's why I advocate. I want to give back. It's time to pay it forward. Okay, for the support that I was given from not just my family, it was really just from my community that came forward and embraced me and gave me a place to go where I felt like I wasn't alone, and that I was sitting in a room full of people that were in the same boat as me. That made all the difference in the world. So, recovery coaches are something that they don't need a lot of job experience. They just need to be in recovery, and they need to be interested in recovery and have a real interest in wanting to help people. And I think that you can move mountains with people like that.
That's awesome. We've got 4 out of our 12 or 13 staff members now who are lived experience in our organization. And actually we're hiring for one more. That's a really good idea. And we could hire for this. I probably shouldn't be saying that on this call, but.
Right. And Gary just posted in the chat. He's right. Very good clinical oversight is critical. I couldn't agree more with you, Gary. I couldn't agree more. Jerry, I'm sorry, Jerry. I couldn't agree more with you. That is absolutely critical. So look, I'm just going to tell you guys a little tiny story. I was working in permanent supportive housing right after I got out of rehab. I got offered a job. My background's in child support. So before I got sick with addiction, I was a child support officer for 15 years. So I had some of that experience in a different field, but I still had it. And I started working as a case manager. And one of the first things I did is I brought over my old drug counselor from my rehab to work as a case manager in my facility, because he's a certified drug counselor. And now he's like the senior drug counselor in that whole facility, and he's like second in command of that whole program. And so he's a guy with lived experience, and he has the clinical experience as well to offer real wraparound services to people, and he's making a huge impact where he's at. So those are the kinds of people that you can find. You never know what you'll find when you go out there and look.
And that, I think, Althea, one of the things that I really liked what you said, I'm sorry, Alethea.
It's okay.
One of the things that you said that I really liked was, and this is the distinction between private organizations and organizations that are funded through the continuum of care or through the government, is setting expectations and holding people accountable to those expectations. In the program that I worked at, that was a high barrier program, the expectation was, look, we all of our residents are going to be, servant leaders. We're all going to be engaged in one another's recovery. We're going to contribute to one another's recovery. And there was probably a 70–80% history of substance use disorder among the residents. But even the folks who didn't have substance use issues, they committed because there was an expectation that we were going to support one another in whatever our challenges are. If it was challenges with getting your GED, if it was challenges with workforce training and employment, if it was challenges with trying to qualify to get your kids back from child support services or whatever, there was this expectation, and I think that the power of expectations and the power of community support, I think that's one of the real tragedies of these federal policies that have come down from HUD and into communities. It just disincentivizes so much good community work. I'm not suggesting that it can't happen, but it's just disincentivized. So we need more of that.
Thank you.
We're kind of at time, but here's the deal. I did want to ask you, Tom, are you familiar with the Miracle Messages efforts out of San Francisco, the reconnection efforts?
I am very familiar, and I'm very close friends with someone that works with Miracle Messages, yes.
I think it's amazing. And they have, one of their components is a peer support program as well, a mentor program.
Yep.
And Lake County uses that in their pit count. They ask people, they explain the program during their pit count, and they ask people if they would like to make an attempt at reconnection. I just think it's incredible.
And Teddy, before we run out of time, may I ask you one question?
Yeah,
Would it be okay? Okay,
sure.
So look, earlier in the presentation, and this is for everybody too, you showed a slide from the California Policy Lab that talked about the rates of people with substance use disorder and mental illness that were sheltered versus unsheltered. Why is there such a disparity between that and the point in time report that are the point in time reports that are done in every county?
Well, we didn't get into that, but you know, that was another fun focus group that Webster and I did with some TA friends. There's some flaws in the point in time count. We should make another leverage bite out of that.
Right, which leads me to my next question, is that why are we basing our funding decisions off the point in time report when we have better data from the California Policy Lab? Just a question. Just a question.
Right, Tom. That is the right question. And this is what absolutely frosts me, is that we have folks at the county level, we have folks at the program provider level who know that the data is juked and know that the program is not serving them, and yet they keep their heads down and they are. I mean, this is the thing. If I'm going to get passionate, I'm going to get passionate about this. When you have 3 to 4 people dying in San Francisco a day and 4 to 5 people dying in Los Angeles a day because people are keeping their heads down, yeah, reprisal is real, no doubt. But they're keeping their that is such. I mean, I can't even get out the words. But that's what's going on. It's unfathomable.
Yep, it's a shocker.
Okay, guys, I'm willing to stay on late, but I know people probably have to go. But just in a nutshell, I want to know about the advocacy. Who are the noisemakers other than you two, and Nola in Austin? What's actually being advocated for? I know, Paul, you've told me about recovery beds, and I detected through your San Francisco DA post, Tom, that there may be changing public sentiment about some things. So I'd like to know, are you guys starting to see any progress here?
Yeah, little by little. And the sad thing is it's not so much my advocacy, it's the fact that there's 650 people dying per year in San Francisco. I hate to say it, but like that, people don't like death. They don't like to be surrounded by that. And it's shooting, that is the greatest piece of data, if you just want to look at data, that you could possibly use to shoot holes in all this ideology around what the real issues of homelessness is the overdose deaths, and the fact that most of them are happening indoors in permanent supportive housing. It's like I want to pull my hair out. But yes, there are people making noise. I'm making noise. Michael Schellenberger is making a lot of noise on the national stage with his new book, San Francisco, that came out. My story's in that book. I'm part of that. You know, there's a lot of people. Soledad Ursua down in Venice Beach is making a lot of noise on the homeless issue. So the voices are rising, and they're voices from the middle that are rising politically from the middle on this issue of homelessness, where we recognize that it's going to take a little bit of both from both sides, like some accountability mixed with compassion, harm reduction, all put together, gelled together into something that's going to help reduce the homeless crisis a little bit.
So you guys are sensing like a change in direction, kind of? A change in sentiment, I guess, is what I'm asking.
Yeah, I think there's a growing drumbeat of people recognizing the significant contributions of addiction and mental illness as a driver of homelessness. Now, I don't want to get an argument, you know, people are like, oh, well, you're denying I'm not denying the economic factors. I'm not denying. I'm just simply saying that it's a growing sentiment that people are recognizing what has been kind of in denial, and that is that, you know, addiction and mental illness are significant drivers in homelessness. And at the end of the day, the advocacy is going to come from people, you know, on city councils and the public who were saying, I don't know what to do yet. We've tried everything and we're stumped. And people are going to start demanding. I mean, that's what's happening in Los Angeles. People are demanding better answers. They're starting to turn that way. You've got Governor Newsom, who basically now making a connection, a stronger connection than ever between mental illness and behavioral health and homelessness. So yeah, it's starting. It's slow. I think a lot of the advocates that I work with on the mental illness side are worried that, like most things, this is going to be co-opted and it's going to turn into the same funding for the same players under the window dressing of something else that the public thinks is going to happen. But I think like in Los Angeles, the city and the county were sued because they weren't living up to their responsibility to people on the streets. We're going to see significant number of ballot initiatives coming up in June and in November on everything from reforming Prop 47, Prop 56. You're going to see local ballot initiatives holding the cities accountable for not removing encampments and the nuisances created by encampments. So there's a lot going on, and it's really coming from kind of grassroots. But and that's why you're seeing the electeds starting to respond, because they've got their finger on the pulse of what's going on in the communities. You saw what happened in San Francisco with the school board. I mean, absolutely freaking amazing. Yeah. But that was because people are looking at what's happening and they're saying, we can't continue down this path. We've got to make a change, and that's going to happen on a lot of levels pretty soon.
Okay. So I will tell you what my one piece of advocacy is that we need a single data system in the United States, similar to what SAMHSA has. We need to stop wasting billions on dispersed HMIS systems and too much difficult training, and not to damage anybody's personal identification or turn anyone over to law enforcement. But just this data piece. As I looked at AHAR today, the only AHAR Part 2 I could find, Paul, was 2018. So that's really where the methodology comes up. So that HUD has not stated AHAR methodology now in 2 cycles, and that's too slow. That's too slow for us to identify problems and make solutions on. So
yeah, I think the problem with the AHAR is that it serves one purpose. And the purpose with the AR is for HUD to submit something to Congress that nobody reads.
Yeah. Well, I read it, but it's deep.
Oh yeah, well, yeah. Is it helpful? I mean, is it helpful? Does it provide iterative policy decision-making information?
No. No. It feeds a lot of the national advocates, and like I've written to them in the last 2 days too, to say, where are you at on recovery and not hurting your response? So we cannot have a non-responsive communicative system if we're going to get anywhere with this problem. So Alethea, you had another question, just one more and then we'll wrap.
Sure. It's just about the platform Unite Us service provider platform.
Right.
Have anyone heard of it? You have, yeah?
Yeah.
What
I
is
know Sonoma County is looking into it.
Okay, awesome. We've been using it since last fall. And I know the strength is in numbers. The more people that join, the more providers that join, the more effective it's going to be. I'm just curious, is really your opinion about it so far?
Well, I think I can speak to those platforms in general. Lake County is implementing that type of a platform in April as a service hub, and I think they're very, very valuable. Where we tend to go off the rails a little bit with software and platforms is we all want to do our own thing. So we don't really have like that coordination of data. So it might serve a provider specifically really well, but to get like what the state of California is doing with the homeless data integration system is amazing in my view. However, I'm waiting for it to mature, because right now, all we're looking at is demographics and a few service patterns. How many people in Sonoma were served in Mendocino? How many people in Lake came from Mendocino? But I think we need, they're continuing to build it out. But I think my work in Alameda for the past 3 years was on data exchange pulling about 20 different data sets together in one software package. So providers could see the health record, the criminal justice record, the homeless record, all the records for a whole person care case perspective. So I really believe in those, but I like how these systems, I love the HMIS for its complexity, because I like solving problems, but I don't think it's a very effective platform for what we're doing. So unite us.
And I don't think it serves the communities who it's supposed to serve.
No, I don't either, Paul.
You know, one of my big advocacy points is to encourage cities to start collecting their own data, collecting data that serves them in terms of what their objectives are. For example, if your objective is to reduce the number of people that are living unhoused on the street, then you need to start collecting things like how many people were referred to shelter or housing, how many people refused, how many people, why did they refuse, where are they now, you know, those kinds of things, and that's, to me, that's really useful data. I don't understand why people don't ask that data, because it has direct, you know, it has direct correlation in terms of, okay, well, you know, are we asking the right questions? Do we have shelters that are accommodating for that people actually want to go into? Why not? Are there other drivers that are incentivizing people to refuse housing and services? What are those drivers? So I think, you know, I think the data collection part is so important, and I really think that cities need to start collecting their own data that serve their own needs, and then be able to kind of, you know, show off that data and the analysis of it, and compare it with the continuums of care are doing. If you just did a cursory project on local data to serve local needs and compared that with the COC, people would be astonished with the comparison.
I agree.
Well, Paul, Teddy can put you in touch with Don Schwartz.
Yes.
He's been in touch with Don Schwartz.
Yeah, we talked. Great.
Good.
There's so, that's the other thing is there's so, I mean, if you really want to talk about the power of changing and changing policy and perception, in my view, and maybe I'm just too much of a nerd like Teddy, but it's about data. And the question then is, who's going to fund it? How are we going to get the support? Who's going to fund it so we can actually make these cases? You know, in my consulting at Chico, they just created they just had a lawsuit settlement, and part of the lawsuit was they created a pallet shelter site. It's got 177 beds in the pallet shelter. They're required to offer services, but they're not, you know, nobody's required to accept services. So I'm just gonna, I told the city, I said, you need to ask how many people are in, out of 177 beds, how many beds are being utilized, how many people have been offered services, what services were they offered, how many refusals for services are you experiencing, how many people are actually completing services, and what's the disposition of that? I mean, those are standard performance measures that if you were in the private sector, anybody would want to know about the product or service, but somehow it's just, it's you know, nobody has a brain to really engage on that stuff at the local level to see what they're doing, if it's actually working. I see Frank's hand up. I touched the nerve.
But I wanted to ask a question, Paul, because I apologize if I sound weird. I'm in an airport lounge, so I'm trying to be a little bit
Congratulations.
He's in CTAC though, so that's great.
Yeah, I'm in CTAC. Yeah. Actually, specific to that, I was following what's been happening to Chico the past couple of years, and I know that there's been some back and forth. You know, the mayor was ousted, city council was changed because there was the response to a tremendous amount of unsheltered homelessness, and there was a lot of problems with the needle exchange program up there. So I was following that with interest. What I'm curious about is I understand that they used an old like BMX track, and that's where they put those pallet shelters. So what I'd like to know, and I'm curious, is specifically, with those pallet shelters, was there also a concurrent enforcement of no camping laws in the parks and on the streets? In other words, was there any enforcement to comply with Boise v. Martin?
No.
No.
Well, the answer to the question is yes, but to comply with Boise v. Martin, but essentially what's going to happen in Chico is that for the next 5 years, the city of Chico has no legal ability to regulate public spaces. All of the incentives and all of the action is conditional on the plaintiff's attorneys and their outreach efforts and the acceptance of people who are living in public spaces on whether or not they want to accept housing and services. So that's
carrots and no sticks. So
carrots
there was
and no sticks, zero sticks.
So if an individual, for whatever reason, rightly or wrongly, decides to turn down an offer of a pallet shelter for whatever reason, and they're camping wherever they happen to be on some city street in Chico or in the park. So you're saying is that there's no ability to enforce any kind of, you can't make them move along, in other words, even by having all that shelter and demonstrably showing that you have beds available, and not even beds, frankly, a private, let's face it, it's private tiny home. So even then they have no ability to regulate the social norms that we've been used to for decades. Right. That, if we have space for you, if there's some sort of quote unquote charity offered to you, there should be some compelling that you should be compelled to take it.
Right.
But you're saying they're not able to do that there.
Yeah. In practice, it's not going to happen. In practice, it's not available. It's not going to happen. And if you read the settlement agreement between the plaintiffs and the city of Chico, all the power is in the plaintiffs. There's no provision for the city to really do anything assertively to reclaim public spaces, even for folks who have refused services, even for folks who decide that they want to move from this public space to that public space. It's a really difficult settlement agreement to read.
How long until all the pallet shelters are built and available? Or
they're all built. They're all built. I think they just selected a provider, someone to manage them, and I think they're trying to basically get everything spun up in about maybe 4 weeks, 6 weeks, something like that. So we'll see what happens.
Are they going to double up, or is it for one individual per pallet shelter? Or are they going to double up like Los Gatos and Santa Rosa?
Each pallet has 2 beds, but the doubling up is at the discretion of the person who is occupying the first bed.
Mm-hmm. And do you know offhand? I can go look, but do you happen to know off the top of your head what the total outlay was for all those pallet shelters?
No, I don't have that off the top of my head.
We can get it though, Frank. We can get it.
Yeah, the only reason I'm asking is just because, again, what's interesting about, because, when you talk about where do we go from here, a lot of the discussion and a lot of I think the roadblock turns into funding, right? Because a lot of you have already elucidated about housing first funding streams, and a lot of COCs, that's all they know. All they know is low barrier housing first. And Teddy and I have talked a lot about all of her work and some of the things that she's been able to give me information wise, that we essentially have 3 funding streams, right? We have low barrier housing first, we have public-private partnerships, and then we have philanthropy, which may or may not be faith-based. So unless I'm missing something, that seems to be the issue I'm finding, especially where I'm living now up in Deschutes County, is that frankly, they grab the state money and the federal money for Project Roomkey, right, to purchase the hotel or a motel and renovate it, right? Okay, great. So you get 40 units or 20 units or whatever. But once that runs out after 1 or 2 years, then what? And so what I'm finding is that people are very well-meaning, they're very compassionate, and the service providers and the advocates really want to help people. But we always keep running into this issue of the funding streams, where's all the money going to come from? And then meanwhile, they spend millions of dollars on all this other stuff. So that was the only reason I was asking about the pallet shelters, is that it's pretty astounding that such a small city, frankly, was able that many. I was actually quite surprised. I was like, okay, where did that money come from? How was it funded, and how quickly?
And you're right in terms of your funding streams, except for two other sources: municipal general funds and county general funds. There's no strings on those general funds. They can use them for whatever they want. The challenge, though, and what the continuum of care has been very effective in doing, is making sure that local communities leverage those funds to increase the increase continuum of care funds or state funds or whatever. They're trying to make sure to leverage those funds, which is a smart thing to do. It's the right thing to do. It's the incentive thing to do. But and this is my biggest argument against the continuum of care dollars. The strings and the regulatory requirements are so strong, they influence what happens at the state and the local level, so that there really is no discretion. So I'm kind of making a fine point that, yeah, if a municipality or if a county really wanted to use their discretionary dollars to do things, they really could, but they would have to overcome so much inertia and so much challenges that it's really not an option.
I want to make sure, Jessica, you've been pretty quiet, and Brian, I know you're hanging out there, and then Carl, if you all have any questions, we can do this again, certainly, but do you have any questions for either Tom or Paul?
I don't. I'm just all ears. I'm just fascinated to hear a different perspective, especially Tom's, because his experience living on the street. But no, I just appreciate the opportunity to listen to what everybody's got to say and try to wrap my brain around this crisis that we're dealing with. So I just want to thank you for that.
Yeah. And
Thanks,
Carl, I did let Tom and Paul know that you had experience in law enforcement in the city of San Francisco, but I'm sure that some of these stats and charts were a little bit surprising to you because it's blown up so fast, down there in the city. So, okay, great. Jessica, are you there?
Yeah. Hey, it's me. So I just want to say thank you guys so much for your advocacy, because this was, I'm fairly new. I just started in July working with COCs and joining meetings and discovering all the funding sources and, the types of housing. And I haven't heard a lot of mental health issues or addiction tied to any of the, housing funds that we're getting. So every time I've brought up, why can't we do another treatment center with some of the funding? Isn't that considered housing people while they're getting, treatment they need? Or I guess I'm just not familiar enough with funding sources and what they're allowed to be used for. But I think it's a critical piece of solving this, this housing crisis or homeless crisis, and we were just ignoring it. And every time I bring it up, I just feel like I'm so new and not confident that I just, nobody takes me serious, nobody engages in the conversation, and it's just, okay, thank you for sharing, bye.
Yeah, so it's not so much denial as that there's deliberate, what's the term, Paul, where they're deliberately ignoring the problem because they are trying to view it as it not being a problem. And that's where the drug policy part of it comes in. And that's the thing I'm pivoting towards in my advocacy. Look, so you can talk about homeless policy all day long, but if you're not talking about drug policy and how that's affecting homeless policy, then you're missing part of the equation, because the two are definitely intertwined and one influences the other. So if you're going to study and learn about homelessness and be in the industry of helping people with homelessness, you should also do research on drug policy and get yourself up to speed on that too, because it's rapidly changing and it's rapidly moving in one direction, rapidly moving towards drug normalization and decriminalization. Regardless of how you feel about that, it's moving in that direction, and that does have an adverse effect on the issue of homelessness and how we look at homelessness and how we look at the funding for homelessness, because those things are deliberately being ignored in certain factions and certain groups that are helping to direct some of these funding streams towards different programs. Let's put it that way.
Yeah, my recommendation to you, Jessica, if you want to know what's going on in the streets, do some ride-alongs with some law enforcement. Law enforcement know every person in the city, and they know who's new, and they know what's up, and they know who needs real legitimate help, and who's who's out there grifting. So in my view, they're and the hot teams are good. The hot teams are pretty good, but patrol is even better.
Yeah,
We just got that here. The new cahoots type model policing for the city of Santa Rosa.
Yeah.
when you guys were talking about, a smaller scale, like the cities doing their own homeless accounts and things like that. We live in a really small town, Cloverdale, and so we're very familiar with the chief of police, and we're on a small homeless task force team, and so we're pretty familiar with all of the homeless people, except for they don't fit into any of the housing programs that are available because they refuse services. They don't want shelter. They had to be rescued by helicopter down at the river after being warned the night before and offered shelter that there was going to be flood. There was a huge flood warning. So we know that these people cannot make decisions, that are in their best interest, or, they jeopardize their safety and all of these other first responder safety. So we know as a small community, the unfortunate part is that the COC is not going to give us what we need because they need to spread it out to the entire county. And so I wish that we had our own COCs in every town,
Well, and actually, you know what, that's not a far-fetched thing. So tomorrow I'm going to Venice, California, Venice Beach, and there are community groups that are doing their own point in time count. They're doing it on the reg. They're doing it like every month or so. They're finding drastically different outcomes than what the COC is finding. And they're also doing their own coordinated entry system. So these are just community groups that are saying, look, the COC is not serving us. We're going to do our own parallel effort, our dime, our time, and so I'm going to talk to them a little bit more about what they found, how they're doing it, who's how the community is being responsive. But here's the point. Why are they doing this? They're doing it to essentially cover their rear ends because they're not getting served by the people whose job it is essentially to serve them. So I see more and more cities starting to move in that direction and saying, look, we're not being helped by the COC. We've got to do this to be responsive to our constituents. And that's why whenever I talk to a community, a city council member, whatever, I say, you've got to collect your own data. You've got to collect your own data because what's going to happen, so here's the story. In Vista, California, where I live, population 110,000 people, not a lot of people. In 2019, they counted every unsheltered person in Vista, California, and they came up with 174 people. Not a lot of people, but just, stick with me. Out of 174 people, what percentage do you think express some kind of drug addiction? Oh, if you said 50%, you're right on. Exactly with what that Cal Labs survey said. The same thing with respect to mental illness, the exact same percentage of the Cal Labs in terms of mental illness. And then they made sure that they said, well, look, they took down the data. They said, we're going to offer housing, we're going to offer shelter, we're going to offer services. And every single person who refused it, we're going to say how many people refused services, how many people. So when it came up at the city council meeting, the one city council member said, look, we don't need a shelter in our community. We rent shelter beds. We have shelter beds on demand in one of the local communities, next door or adjacent to Vista. We don't need a shelter bed because we have 174 people that are living unsheltered in Vista. Every single one of them has been offered shelter and has been offered services, and every single one of them has refused. And that's the power of collecting your own data.
Hey, Paul. One quick question, and also for Tom and even Teddy as well. Has there been any advocacy, any movement on possibly changing the Letterman-Petra Short Act and or Laura's Law? Because just what Jessica just reminded me, that's another problem a lot of places have, right? Is that if you offer these things to people and they refuse, what tools do we have, law enforcement or otherwise, to compel people? And if we can't compel them now, like you were saying in Chico, then what is happening on the front of actually changing these laws or making Laura's Law have more teeth, or changing the Letterman-Petra Short Act?
Yeah, so on LPS reform, Governor Newsom has actually acknowledged that part of his long agenda, in addition to spending what, 34 billion surplus dollars that we didn't expect to have. That was sarcasm. But part of his agenda is to reform the LPS law. So what that looks like, how that looks like, we're not quite sure yet. But I'll tell you this, part of the challenge of the LPS law is not just compelling people to take treatment, it's also to finding places for them to go. Because a lot of these docs and a lot of these referrals that are that are presiding over people in 72-hour holds, the reason that they don't refer people to a facility is because there are no beds available. So that's why they kick them back to the street. So that's a real problem, and that's not that doesn't have anything to do with LPS necessarily. With respect to Laura's Law, that's a county issue in the state of California. Every county opts in whether or not they want to enact Laura's Law and provide assisted outpatient treatment. So every county is different. Some of them are being true, and like San Diego County, they opted into Laura's Law, but their administration of Laura's Law is really crappy. So there's a whole other implementation side to it. But here's the other thing that's happening. So there is a ballot initiative that is on the books in Sacramento, and there's another one that was filed in Los Angeles that will create a affirmative cause of action for businesses and members of the community for the city to respond to encampments that are found to be nuisance or that are depriving people of the use of public spaces. So there's some movement acting on the whole regulation of public spaces front, and so it's an interesting take because it gets around the Martin v. Boise decision, and it creates this different cause of action that will essentially cause conflict with Martin v. Boise, and the hope that that conflict will actually result in some kind of higher court challenge for that.
And to think that, like in 2015, I had a hope of, I told David Lewis tonight, Paul, when I left Sonoma County, I thought, oh, if we just did better at the data, we could solve this. So look where we are now. It's probably time that we should break up, but I would love to have both of you back at another time. And I hope to heck, because I'm doing multiple computer futzing around tonight, that my recording of this actually worked, because this was really pretty freaking amazing. I'm so impressed with the level of conversation that came up tonight. And I'm really glad that some of my CAN friends could be on the call, because, these issues become they're so simply easy to solve if you're just a community member, but without knowing all of these layers and these blockers, it is just, and I'm only talking about the HMIS myself, trying to get people understanding how to put a basic piece of client record in the HMIS. So this is, it's good that people kind of see the levels of complexity. Sometimes I don't know if this is solvable morally, I say. So anyway, thanks everybody. And I will I'll let you know if the recording worked, and then I have some of the resources to email out. If the recording worked, I'm going to send it on up to YouTube tomorrow. And I'll let everybody know. So yeah, so thank you. And Carl, thank you. I guess who's probably, kind of an eye opener. And Brian, thanks a bunch. I'll regroup with you tomorrow on distribution scores. So
Thank you.
Thank you.
Katie.
It was
Thank you, everybody. Thanks
it was
for
nice meeting everybody. Thank you.
Yeah,
yeah.
thanks, Paul and Tom. Really, really appreciate it.